Hi, and welcome to Health Connections on KCAT Television, Los Gatos, Monte Sereno. I'm Dr. Stuart Menakar from the Palo Alto Medical Foundation, Los Gatos Center. Welcome to part 2 of our cardiology shows today. Last time we met with my colleague, Dr. Amin Manuchehry, and we talked a lot about cardiovascular disease. And today, we're going to have the pleasure of more time with Dr. Manuchehry and also get to see him in action. So I hope you'll enjoy the show and look forward to seeing what happens when a cardiologist is checking on someone's heart in the cardiovascular laboratory. So what do you do when you're there in the catheterization? What actually happens to the patient, and how do you know if there's heart disease?
Sure. So the patient we have today is a 71-year-old man, history of hypertension, dyslipidemia, type 2 diabetes. He presented to me last month actually with symptoms of exertional chest pain, shortness of breath. We did a stress test which was very abnormal. We brought him for this cardiac catheterization. This was last month. He's back here today because on his other side, the right coronary artery had significant calcification and disease. Basically, there's rock sitting in these areas that's going to require treatment. So what we did was we're performing a staged intervention. So we fixed one side of the heart last month. He's back here today to fix the other side. What does an interventional cardiologist do? Well, it's a procedure that's catheter-based. So, minimally invasive procedures where we use the highway of the body, which is the vasculature, which, the heart, as I mentioned, is a pump that sends blood out to the rest of the body via the vessels. Now, the vessels also go back to the heart. So I can go in any vessel and try to get back to the heart. For us as interventional cardiologists, typically we'll use the groin vessel, we call the femoral artery, or the wrist vessel, we call the radial artery, to get back to the heart. So we can put a long tubing of plastic along with a wire that can thread us back to the heart and inject contrast dye to really look at what's going on in the heart. Are there blockages in vessels when we inject the dye and look under the x-ray? And that can help us understand what's going on and then certainly make management decisions, whether that be going and putting a balloon to open up a blockage and putting a stent, which is basically a metal scaffold that helps keep that blockage open, or deciding that, this patient has multiple blockages or blockages in very high risk areas, in which case we might say, this is not the role for an interventional cardiologist, and we should decide perhaps surgical bypass is the correct route of management. So, we work closely with our surgical colleagues to help, provide the best care we can for our patients. Certainly patients want to avoid a surgery if possible, but from our standpoint, we want to make sure we're making the right decision and looking for, both short-term and long-term benefit. Sometimes that may be with a stent, and sometimes that may be with bypass surgery. And that decision is made in conjunction with our surgical colleagues and certainly the internist discussing what is best for the patient. So you can see here in the right coronary artery, there's an area in the proximal portion and the mid portion. There's some calcification. The lumen is very narrow up here and here, so we'll fix both of these spots. Otherwise, the vessel looks pretty good size. You want to be more asleep, or are you comfortable? All right. You tell me if you need more medicine. We'll do a rupture. So we just finished the case. Patient's doing well. It turned out to be more challenging than anticipated, but that can happen. We had to change from the wrist axis, the radial artery, to the groin axis, the femoral artery. And once we did that, we were able to seat our guide catheter better, get our wire down, do the drilling part of the procedure, and now put the stents. Here's one stent we put in the mid-right coronary artery. And then we put another one up in the proximal portion. I'll show you the final pictures here.
Right groin.
So now you can see his vessel looks nice and open. So all that calcium that was causing occlusion has been stented with two stents. So I think he's going to do just fine.
So one thing as a primary care doctor here at the Palo Alto Medical Foundation, Los Gatos, that's very important to me, I appreciate so much, is working with a wonderful team. So Dr. Manuchehry, as he said, is an expert in internal medicine, but he has training beyond that. He's an expert in understanding how the heart works, how to prevent troubles with it, how to treat them when they're there, and even to the point of being able to put little tiny tubes called catheters inside the heart blood vessels and open them up to put things back the way they should have been. But maybe lifestyle changes or genetics have made it so they don't stay open on their own. Literally to give your heart a longer life. He can do that during a heart attack, or what we hope is if you're having heart troubles that we've discovered from your symptoms that there's a possible future problem, and Dr. Manuchehry can prevent that. But as he said, he's part of a team. And here in Los Gatos and throughout the Bay Area, we have a team of heart specialists and surgeons and other physicians who work on the heart who treat more patients and have a bigger group of doctors working than almost any organization in the United States. Certainly bigger here in the Bay Area than any other of our academic institutions or other service providers in Northern California. So that to me is a wonderful feeling, know that I have that backup and support, whether or not it's an elderly gentleman with shortness of breath or my patient who's having a heart attack and shows up in the emergency room. So these are things Dr. Manuchehry can do, and our other colleagues, to help when there are troubles that are there. I do want to take just a moment too and talk about what happens after you have a catheterization. What happens if you go in with that tube and the stent, which is something to open up the blood vessel, and everything's fine and the patient goes home? Or what if they've had a heart attack? Does that mean no more soccer, no more sex? What does it mean if someone's had a heart attack?
That's an excellent question. So, thinking about the patient who's had a cardiac event, whether this is a heart attack or they've had chronic blockages that have built up and had needed to be opened up, I think it is important to think about the patient's body, mind, emotional standpoint, because all this affects the patient's quality of life. Certainly from a medical standpoint, we institute certain medications that we know that are meant to help prevent further progression of disease, to help stabilize a stent if one has been put. These are things like aspirin, other antiplatelet or blood thinning type of medications, certain medications for cholesterol, blood pressure, and these are essential for maintaining optimal health in a patient who had some kind of cardiac event. Certainly from a psychological, emotional, mental standpoint, I think it's important for patients to get past whatever event has happened. Certainly in the early period, we focus on the medical therapy. We let a patient kind of recover from that procedure, which typically is quite short, but we want them to get back to regular activity in a controlled, modified, graded fashion. Oftentimes, we will send patients for cardiac rehab, for exercise in a monitored setting, to give them the confidence in a monitored environment with healthcare professionals to help them move forward, both physically, both mentally, which is so important for the patient's overall health.
People can get back to vigorous exercise.
Absolutely. I wouldn't be doing what I'm doing if that was not my hope. And not only that, I hope that patients do better than what they were doing before, that they feel better, that they're more active. So, I'll tell patients, this is not, this procedure or your heart attack was not a way to scare you to do less in life, to be fearful of what may come. Quite the opposite. I tell them that we want them to do more, that this is a second chance perhaps, that this may be a time point for intervention to really change the course of their health and their quality of life, to move forward to more exercise, to lifestyle modification, to following up with their doctor regularly who maybe they haven't been doing so well before. I think that's so important that this is all part of the patient's experience, that yes, they've had this event or they have this cardiac condition, but to not use it as a crutch, to not use it as something to hold them back, but in effect, really get them well so that they can improve and be better than they ever were.
That's a wonderful point. I really appreciate that you brought that up, because in a similar level to what we talk about as preventing heart trouble in the first place, whether folks have a catheterization or a bypass surgery or other intervention with you, if we know they have heart disease, we can prevent future problems in a similar fashion with lifestyle modification guided by their heart specialist and perhaps cardiac rehab folks. Also with medication. I know that we give medication to folks after they have a heart attack that have an enormous ability to reduce any possible future heart attacks.
Sure.
And that's something that our heart specialists and our primary care doctors work on together. It's great that we remind folks that heart troubles doesn't mean the end of everything they wished for in their life.
Yeah, and I would also add that what is happening in the body is a global process, and it doesn't stop after you get a stent or after you get a bypass. And this is why we continue to be vigilant and why the patient has to continue to focus on themselves, taking their medications. This is why the physicians that take care of them have to be on top of them to optimize those risk factors to prevent progression of disease, so that they don't need to see me again for another stent or have to go in and do another intervention, whatnot. So I think it's a process that never goes away, but our goal is to prevent progression, where we keep patients healthy, where they don't need these interventions, and if they've had an event, we know their level of risk and how to manage and keep them healthy thereafter.
Well, Dr. Manuchehry, I hear you talking about issues that are under our own control, like watching our diet, salt intake, watching our weight. You mentioned smoking can be a problem, and we've talked about those with coronary artery disease and other heart problems earlier in our conversation. It sounds like we're coming back a lot to prevention for these problems as well.
Yeah, certainly the goal of primary prevention and controlling the things that we can control with blood pressure, cholesterol, diabetes, all this plays into all the aspects of the heart, whether it's the plumbing system, whether it's the pump system or the function of the heart. It is essential to really focus, and the goal is to prevent the progression of disease that may cause worse disease. And that's really where the focus on primary prevention, seeing your doctor on a routine basis to look for any development and controlling these risk factors becomes essential.
I know that when we talk about prevention, primary prevention, meaning preventing a problem before it ever begins, is sort of a long-term effort. And a lot of us think about heart problems happening only in the elderly. But you and I both know that they can affect people of all ages. Tell me a little bit about who else might get heart disease besides someone who's smoked too much over the last 50 years of life.
Yeah, like anything, this condition may affect all populations, from small children to adolescents to young adults to the elderly. Why it's so important that we have various cardiologists that focus on different populations of patients, because their management and diagnostic evaluation may be quite variable. There are pediatric cardiologists that we have at Palo Alto Medical Foundation who focus on kids and young adults and who deal with congenital heart disease. There are adult cardiologists like myself who focus on the older individuals. I think it's important to recognize that there are a variety of causes of heart disease, ranging from congenital issues when a patient is born, ranging to certain behavioral aspects in diet, exercise, habits such as smoking, alcohol use, as well as certain things that are not under our control, certain genetic hereditary conditions which a patient may have no control over. So, we have to be prepared and be thoughtful about all those possibilities to be able to diagnose and properly manage and treat these patients.
I'd like to move our conversation next to the topic of heart failure. Can you explain to our viewers a little bit about what we mean when we say heart failure?
Sure. So, as you said, heart failure is a scary term, and it really refers to a group of signs and symptoms, which I'll get into shortly. But ultimately what we want to do is find the cause and underlying problem leading to heart failure. Now, heart failure may cause symptoms of short of breath, swelling in the legs, weight gain, fluid overload, and there's a lot of different causes of what may be contributing to the development of heart failure. And so the goal for the cardiologist is to evaluate the patient using different tests, exam, modalities, to identify what may be the cause of heart failure, to find the most effective therapeutic modalities to treat the patient.
A lot of patients in my practice, when I mention that they have a diagnosis of heart failure, they're worried that their heart's about to stop. Does that mean my heart doesn't work anymore? That, I'm a goner?
Yeah, so, heart failure is really, we can group it into two types of dysfunctions. The heart has a job to squeeze and get blood to the body. It acts as a pump. The heart also needs to relax to allow the heart to fill well. We look at group heart failure to two things, whether it's a squeezing problem or whether it's a relaxation problem. So, and those patients, some of the medications we use are, can be used in either one of them. Some of the therapies that we prescribe to patients depend on the underlying cause of the heart failure.
In some patients, it sounds like you're saying we need to use medicine to make it easier for the heart to squeeze by removing extra fluid or something like that from the system. And in other patients, it may be more important to relax the heart so that it has time to catch up and do its job.
There are proven medications with a wealth of data behind them that we use for patients with heart failure. These are beta blockers, ACE inhibitors. These have shown to improve the quality of life and reduce mortality in patients with heart failure. And also for symptom management, we use things like diuretics or water pills to get fluid off of patients. Again, ultimately we want to find the cause. And by focusing on the cause, we can hopefully reverse that. Now, the cause may range from blockages in the heart vessels or coronary artery disease, what we call an ischemic cardiomyopathy. It may be related to an underlying valve problem. It may be from patients who have uncontrolled, long-standing high blood pressure. So there are a variety of things that we try to tailor both for general treatment of heart failure, but then based on the patient's cause of their heart failure, really to focus on that.
Heart failure doesn't mean it's the end. It's treatable.
Absolutely, and there are millions of people with heart failure who are walking, talking, who are active, who are exercising. It's a condition that doesn't necessarily affect the elderly or the young. It's really prevalent throughout all populations of our patients, and there are different causes, as we talked about. So, no, I think the goal is to identify patients with heart failure, to start the therapies necessary to improve their quality and quantity of life. Yes.
So most of the time, as you've mentioned, we can treat heart failure with medication, but are there other treatments that we might need sometimes in extreme cases or in folks who don't respond to medication well?
And I would start saying that in the diagnostic evaluation of patients with heart failure, depending on whether this is a squeezing problem, or we call systolic dysfunction, or relaxation problem, or diastolic dysfunction, most patients, depending on their level of their risk factors, which we've talked about before, diabetics, smoking history, high blood pressure, those patients may ultimately require an angiogram or cardiac catheterization. One of the most prevalent causes of heart failure is blockages in the coronary arteries, that we call ischemic cardiomyopathies. And why that's so important, because this is potentially reversible. That if there's a 90% blockage in one of the vessels causing some dysfunction and leading to symptoms of heart failure, well, by opening up that blockage or blockages, we can really improve that patient's heart condition and really get rid of the heart failure so that they don't develop those symptoms. So that's an essential part, that this angiogram, whether a coronary intervention to open up blockage or bypass surgery to open up the plumbing system as we talked about before, may be very important. Other aspects aside from the medical therapies that are so important include there are patients who may require a defibrillator. These are devices that are used to monitor patients' heart rhythm, and for certain patients with a very weak heart, this device may be a life-saving therapy to prevent sudden cardiac death, which is one of the big fears in congestive heart failure with a reduced squeezing function of the heart.
Hopefully not too many of our patients get to that point, but you can take care of them if they do. How do you monitor heart failure? How do you know how bad it's getting without having to do an invasive test like an angiogram?
So much of management of heart failure really depends on patient education. And one of the biggest things, and I really stress this with my heart failure patients, is to take control over their situation. The doctor, whether it's you, whether it's me, we can't be with the patient every day. But weight management is one of the most essential pieces that a patient can take upon themselves to really monitor their progression or their condition of their heart failure. So one of the earliest things we see when a patient's fluid and their volume goes up is their weight starts to increase, usually even before they start to develop symptoms. And really the goal is to keep the patient out of the hospital, keep them as functional as we can keep them. And so having them monitor their weight every single day. I tell my patients, you weigh yourself the same way every morning and you keep a log. And you monitor to see if there's a change in the weight, more than 2 or 3 pounds. Well, that may suggest that things are accumulating. Because change in diet, increase in salt from a salty meal, a little infection such as a urinary tract infection, these may all be precipitants of a patient who is in stable congestive heart failure may become decompensated and develop fluid overload. And monitoring the weight is one of the earliest detectors and ways to monitor a patient to keep them stable, and that may just be they go up on their diuretic dose to get rid of fluid, and that may be difference between them needing to go to the hospital for IV medications and so forth, as opposed to simple outpatient management.
Tell us a little bit, please, about heart ultrasound or echocardiogram and how you use that in monitoring heart troubles.
The echocardiogram is probably one of the most powerful tools in cardiology because it's a non-invasive, safe way to really evaluate the heart itself. So with ultrasound, we can look at the heart size, the heart thickness. We can look at the valves of the heart to see what is the function, if there's any dysfunction of those areas. In a patient with heart failure, it's the means of determining, is this a squeezing problem or a relaxation problem? And that really helps direct further management of these patients and even progression. So I've had many patients who have come to me because they've developed signs and symptoms of congestive heart failure. They've had a evaluation, and after being on the right medical therapies, whether they need just medications, whether they need revascularization with a coronary stent or bypass, whether they need a valve surgery, those patients, when you evaluate them again in 3 months, 6 months, their heart function may have returned to normal. So I think it's important to educate patients that these are not necessarily permanent things, that this is a very dynamic situation where we want to evaluate the patient, identify a baseline level of cardiac function, initiate therapies, whether it's medical therapy or more advanced therapies such as procedures, such as coronary stents, bypass surgery, defibrillators, but monitoring those patients with echocardiogram to evaluate if there's improvement in their heart function to get them into a more stable state of their cardiac health.
I love the fact that you've emphasized that the dynamic nature of heart failure means that many patients who see Dr. Manuchehry or other physicians in the Palo Alto Medical Foundation for help with heart failure end up having near complete or even complete return to normal function. You mentioned when you were talking about echocardiograms or the heart ultrasounds that sometimes we use it to evaluate valve disease. That's something we haven't touched on so much. So could you explain to our viewers a little bit about heart valves and what they do?
Yeah, the heart valves are really the doorways between the heart chambers that prevent backflow or leakage, we call it regurgitation, but also allow the blood to get out to the different parts of the body and between the different chambers. And the ultrasound or echocardiogram is really the gold standard evaluation method to evaluate the function and the status of those valves. Valve can have dysfunction from a variety of causes, some of them being congenital, things you're born with. Other things are diseases of degenerative changes, wear and tear. The same way someone develops dysfunction of cartilage in their knees from age, from wear and tear, the same thing can happen and happens to valves as well. There's really 4 valves that we look at in the heart, and they can become leaky, they can become tight, what we call regurgitation or stenosis. And the echocardiogram really helps to evaluate the function and status of those valves.
Why is it bad if heart valves leak? And is all leaking of heart valves a problem?
Sure. Like anything, there's a gradation of severity. So there may be a little bit of leakiness of the valve, there may be severe leakiness. The higher severity and the longer chronicity to leakage of a valve, the more impact it's going to have on the cardiac function. Some valves can become tight, we call stenosis. So a condition in particular that affects many older individuals is aortic stenosis, or tightening and narrowing and dysfunction of the aortic valve due to fibrosis and degenerative changes. Why valve disease is so important? Because oftentimes it's fixable. There are multiple modalities to fix valves, whether it's open heart surgery, and nowadays there's more minimally invasive methods, non-surgical, where an interventional cardiologist like myself or our other colleagues at Palo Alto Medical Foundation can really intervene and fix valves by small incisions through a vessel in the leg, whatnot, to really avoid major cardiac surgery. And the importance of that is that these can be life-saving measures to prevent future dysfunction and development of congestive heart failure.
Valve disease comes in many forms, 4 different valves. Each of them can have dysfunction in several different ways. So it's a very complex issue. I don't think we're going to spend a lot of time discussing every possible kind of valve disease. That would take many programs to do that. But I do think it's important our viewers understand that Dr. Manuchehry and our other cardiologists and other members of the cardiovascular team at the Palo Alto Medical Foundation are experts in caring for all aspects of cardiovascular disease. We've talked about plumbing, the coronary arteries. We've talked about valves a little bit, about heart failure. We haven't so much addressed the electrical system today, but probably on a different program. We'll do that with one of our colleagues. But most importantly, I hope that our viewers have learned that at the Palo Alto Medical Foundation, we are very well set up to take care of all aspects of cardiovascular disease. My guest today on Health Connections, KCAT Television, Los Gatos Montesereno, has been Dr. Amin Manuchehry. I really appreciate you joining me today again in this second episode of our conversation about health and treatment of heart troubles. So thank you very much.
Thank you
it's
very
great
much.
to have you.